Ladies and gentlemen, dear colleagues, I'm Dr. Giancarlo Marra, Chief Editor of the UROONCO platform. We are here at the biggest European urological event in Madrid, EAU 25, and it is my pleasure to welcome today with us Professor Saad from the University of Montreal in Canada. He will be presenting a Monday morning game-changing session, the results, the updated results of the ARANOTE trial. So thank you very much for being with us and for accepting the invitation.
It's a pleasure.
So notably, the trial randomized 2-to-1, approximately 700 patients in total, metastatic hormone-sensitive disease, to ADT plus darolutamide versus ADT plus placebo, and results were recently published on the JCO, I think in December, and showed an advantage in terms of radiological progression-free survival or death, which was approximately 46% exactly. In favor of the use of darolutamide. From the oncological perspective, what are the new findings you're going to present on Monday, and what are their oncological implications?
Right. So, as you said, the results were positive in terms of rPFS and also in terms of time to metastatic CRPC, time to PSA progression, even time to pain progression, and especially important, PSA responses were much better with the addition of darolutamide, more than threefold chances of getting to below 0.2. So 62% with darolutamide ADT versus less than 20% with ADT alone. So much higher chances of getting to 0.2. And why that is important is very similar to what we saw in ARASENS with the triplet therapy, is that if you get to below 0.2, the outcome is much better in terms of rPFS, time to mCRPC, time to PSA progression, always in the range of greater than 80% reduction in the risk of these outcomes when you get to below 0.2 versus not getting to below 0.2 with darolutamide.
Okay, so you found a significant threefold, you say, greater reduction in terms of PSA, and this correlated to significant endpoints. So,
exactly.
So interesting results indeed.
Yes.
Another, I think, important point I would like to ask you on is we know from preclinical studies that darolutamide may have some kind of advantages in terms of not crossing or crossing less the blood-brain barriers. Did you confirm the previous results in terms of a good safety profile in terms of darolutamide, or do you have new insights on this?
Yes, absolutely. And so this was, preclinically, but we needed to show clinically if that made a difference. And I think it's hard to compare across trials, but within the trial, we were able to show that compared to placebo, there was really very little difference in adverse events. And surprisingly, even in terms of fatigue, there was actually less fatigue in the darolutamide arm than the placebo arm. And treatment discontinuation was actually lower in the darolutamide arm than in the placebo arm. Coming back to the PSA responses, what we did show and look at was how we can get to PSA response in high versus low volume. And high volume disease does much better with darolutamide, as you would expect, but it's more in the 55% of patients get to undetectable. Whereas in the low volume, it's over 80% get to undetectable. And so what do we do for those patients that don't get to undetectable or we know are less likely? This is where maybe we have to have a discussion in the high volume about triplet therapy, where we might expect to get better results. The other aspect that I'm presenting here at EAU is looking at how baseline entry PSA makes a difference. Because many of the studies had baseline PSAs in the range of 5. In ARANOTE, it was 21, which was much higher. But this gave us the advantage to look at patients with low PSA, let's say below 4.5, and 21 or above, which is the median. And we see that if you come in with a lower PSA, you have a much higher chance of being undetectable. And the outcome in these patients is about 90% reduction in rPFS, mCRPC, PSA progression. If you come in with 21 or above, you still have a very good PSA response, but it's more in the range of 50% undetectable PSA. So again, these high volume patients, high PSA, maybe we need to reconsider our doublet approach based on patient profiles and tolerability.
Yeah, so personalized medicine, even for metastatic disease, and a very interesting result. So those with a good response could wait maybe a bit, and those with not a good response maybe can go upfront aggressive treatment. We do not know it yet, but of course it opens new discussion, new insight, and we are looking forward to your presentation and to future results with longer term follow-up from your trial. Thank you very much for being with us today, and thank you very much for discussing about your excellent trial and your results.
Thank you very much for having me.
Thank you for listening.